Council Member Annie.
Thank you, Madam Mayor. Forgive me, I'll be a little long-winded with this.
Take your time, sir.
You know, this is a very complex issue, and it's an issue I am sorry that this chamber has to discuss. I think I want to resonate what Councilwoman Cook said about this. I think at the end of the day, everyone here wants to serve their community the best way they can. But the ecosystem we have in Charleston with drug abuse and what our local hospitals are going through is crushing. So I'm going to go back in time a little bit. So originally, the people that I'm friends with on council know this, I was trained to do toxicology. I was trained to look at chemical factories. And my wonderful wife, who's right behind me, had a job at the pharmacy school in Charleston. And the only job for a lonely research scientist was working in the Heart and Vascular Center at CAMC. So I took that job. That was 7 years ago. The first project we went on, like most West Virginians, I've had family members that have died of substance use disorder. It's been tragic. People I grew up with. It was like a car hitting me right in the middle of the street, going into a hospital setting, because I was a lab guy. I had studied things from afar. And seeing people say, well, you know, opioids with dirty needles, we can have infective endocarditis. When you have a dirty needle, it causes bacteria to transmit into your heart valves, to your mitral, to your pulmonic valve, and a vegetation grows. And what happens is, for more normal people, you know, you come in, you get a port in your chest, 6 weeks later you're fine. But if you have substance use disorder, you disappear. Without a syringe service program or a safe place for these people, they don't trust anybody. So what happens? They sign out AMA, against medical advice. The first project I worked on, I looked through 426 charts of substance use disorder individuals from this city, the surrounding area. Believe me, I wouldn't wish that on anybody. 30% of them died. Nationwide, it's 20%. And these weren't people that were transients, that came from Ohio or Pennsylvania or Virginia. We looked up their addresses, where they were going. They were from here. That was from 2008 to 2015. The updated data, we're working with WVU now, it's even worse. We average 70 cases per year down at the hospital down here. So that means you can be training to be an internist, then do a cardiology disease fellowship, and there's always going to be 2 people in the ICU that have this condition. And we try to save them. We do. Our original study found that the Department of Cardiology lost $17 million in treating these 426 patients. That's not counting the amount of man-hours it took to take care of them through the ICUs. It's a little bit harder for everyone these days to go get a doctor's appointment. Consider that. But it also extends to other disease states, like infections of the skin. Our Department of Surgery wanted to do a similar study. In the same time frame, we saw 1,323 people that had severe infections that came through our program. And it was the same thing. If you have an average infection on your arm or your leg, a lot of people do, you may be in the hospital 2 days. It's an average to 6 to 7 days, with a median stay of $44,000. And again, this is loss. This is time delay of treatment, of care. We have severe sepsis in this community. We have bacteremia. We have osteomyelitis. We have things that everyone talks about HIV. And yes, HIV is deadly. It's deadly from a cost perspective because we found a way, if you can get treatment, to stabilize it. It's $500,000 to $1 million a year. And you know who pays for that? I do. Everybody here does. It's a federal program, and that's the way it should be. But that HIV doesn't stay in the community of the substance use disorder individuals. It branches out. And you meet people that contract HIV, and they're lucky enough to get treatment and get their viral load under control, and it's great. they're able to be saved. Syringe service programs provide something called trust. Because I can tell you right now, going through all these files, there's not a lot of trust in the institution. We try, we really do. We're about as efficient as a hospital as you can be. When a current person comes in diagnosed with sepsis, it's $22,000 to the ED. You asked about hepatitis C. I'll share some numbers for you. I took these today. 2017, 240 cases of chronic hepatitis C coming through our hospital. 2018, 230. 2019, 530. Yes, the Charleston syringe program had problems, but we had an 1,800% increase in HIV after it closed. 2020, 500 cases. 2021, this is when COVID hit, 480. 2022, 740. And as of today, 580 chronic hepatitis C users. And these are people that are active users. So it's very hard for them to get treatment when they're still using. In 2021, this city council passed more provisions and guards for syringe service programs. The merits of this application should be judged on that. 90% return rate, public discourse going through the community, that should be the debate tonight. We have a problem in Charleston with these diseases. Hepatitis C will bankrupt us. There was, one of the speakers talked about the equity aspect of things. And I agree, there should be equity, because it affects every ward here. I represent a portion of South Hills. Get a lot of nonsense said about South Hills, gotcha. I'm a Canal City kid by heart, so don't take it personally. But it affects my people too, because I have a lot of healthcare providers live up there. And when COVID happened, I think we all can agree, it was tough to get an elective hospital appointment. It's gotten worse. We burned out an entire generation of healthcare providers, nurses, doctors, pharmacists, technicians, everybody. Try getting an appointment. We're clogging our EDs up with individuals that could simply be mitigated with having a syringe service program. I understand it's a difficult concern. I understand that there's a lot of emotions here associated with this. But as Dr. Bowe behind me said, the facts are clear. 30 years of research into this shows that these programs work. I'll offer this to no votes on this council right now. If they feel that this program does something ineffective or that they're being disingenuous or anything, I'll be the first with you to pull the letter of support from this council. But the facts are, our city is dying with a portion of its population. It is our responsibility to, as councilors, as a city government, to do something about it. Sitting here, I think about all of the amazing healthcare individuals I work with, like Dr. Bowe, like all of our cardiologists, like all of our staff. Do we really want to say to them, you know, I'm with you, but you just got to work an extra 6 hours this shift. You got to take care of another 2 patients on the floor. Maybe next time around. I'm open to any questions on this floor about specifics of things I've said. The last thing that I'll say is there's not transients coming into the west side for these services. We geocoded everybody to try and be more efficient with our ambulance systems. They're your neighbors. They're up in my ward. They're everywhere. But the west side of Charleston and the wards there in downtown are the worst part of the city, and they are increasing. We have a problem. We need to find a solution. Thank you.
Councilmember Annie, appreciate it.